medication, the medications as follows. Carvedilol, 6.25 milligram 1 tab BID, linaclotine 5 milligram 1 tab once daily, calcium carbonate 1 tab TID, nacaran tablet 1 tablet BID, and sodium bicarbonate 650 milligram 1 tab TID. For the family history, hereditary familial diseases include hypertension and diabetes mellitus on the maternal side. Personal and social history includes a patient is a non-smoker, non-alcoholic beverage drinker, and has no non-illicit drug use. Further review of systems, pertinent positive includes generalized body movement. For the physical examination, examine and awake a febrile, coherent, not in respiratory distress with the following vital signs. BP of 190 over 100 on the right arm, 200 over 100 on the left arm, heart rate is 86, RR of 20, O2 set of 97% at room air, and the febrile of 36.4. For the pertinent physical examination, pertinent negative includes no neck vein extension. For the chest and lungs, clear, noted to have clear breath sounds with no wheezing nor rounds. Patient noted to have distinct heart cells with normal rate and regular rhythm with no murmur. Negative TPS bilaterally, and patient had strong pulses with no bipedal edema. Neurologic examination was unremarkable. For the salient features, I present to you a 69-year-old female and known hypertensive and diabetic with a history of CKD stage 4 last 2019 who came in due to generalized body malaise, decreased appetite, and nauseated with no complaints of fever nor chills, no chest pain nor dyspnea, no cough, no dysuria nor glossomaturia. For the physical examination, examine a weight, a fever with stable vital signs, with equal chest expansion, clear breath sounds, regular rate and rhythm, no murmur, negative KPS bilaterally with no bipedal edema. For the primary working impression, uremia secondary to CKD stage 5, secondary to BM nephropathy and hypertensive nephrosclerosis, hypertensive emergency, and type 2 BM non-insulin required. We are presented with a 69-year-old female who is a known hypertensive and diabetic for more than 10 years, who claims to be compliant with her maintenance medication, and has known history of CKD stage 4 last 2019, who came in due to generalized body malaise, nausea, and decreased appetite. Since patient is already CKD patient, nausea, anorexia, and vomiting, and also this patient probably is already anemic due to insufficient production of erythropoietin by the disease kidney, causing patient to complain generalized body malaise, weakness, or fatigue. Patients with severe hypertension with systolic blood pressure of more than 180 millimeter mercury and diastolic blood pressure of more than 120 with acute target damage such as renal dysfunction is already considered a hypertensive emergency. For the differential diagnosis, my first consideration is COVID-19 pneumonia mild. Since we are still in a pandemic and we have rising cases of COVID-19, and also the patient is also vaccinated, who presented with generalized body malaise, although the patient did not complain or present with cough, fever, nor dyspnea. Patient is stratified as mild since patient has known comorbids such as diabetes mellitus and hypertension and CKD, but that does not require oxygen supplementation and has no episode of saturation. Second consideration is urinary tract infection. Since patient presented with body malaise, although the patient did not present or complaints of fever, dysuria, hematuria, lung pain, or chills, UTI occurs most commonly in female as high as 40 to 50%. Patient is also predisposed to urinary tract infection since patient is a known diabetic and has history of UTI last 2019. And my last consideration is hypoglycemia since patients already presented with body malaise and nausea. Patients with low blood glucose level usually present with feeling of tiredness and dizziness. Some also may present behavioral changes, confusion, and seizure. So here is the chest X-ray of patient VL taken on AP view, which we note the trachea is midline, no bony deformities, the heart is in low, CT ratio of 0.58, However, noted to have easy densities in both lower lung fields and the left costophrenic angle is blunted. This was preliminary read as bibasal pneumonia is considered, left pleural cardiomegaly and atherosclerotic aorta. Also, this is the 12-lead ECG of patient BL, wherein the P wave is upright and precedes the neuroQRS complexes, noted to have sinus rhythm and normal heart rate at 66 beats per minute. The elevation or ST depression noted with an interpretation of sinus rhythm with non-specific STP wave changes. For the laboratory, for the situation was anemia of 10.7 and leukocytosis of 12.01. Patient has from, not mistaken, from X5 last first week. By revised working impression, uremia secondary to CKD stage 5 secondary DM nephropathy and hypertensive nephrosclerosis, hypertensive emergency, anemia secondary to chronic disease, electrolyte imbalance, uh, uh, hyperkalemia, hyponatremia, and type 2 DM non-insulin required. For the ER management, patient was started Isocet drip 40 milligrams. Patient started with ceftazidime 1 gram IV infusion as loading dose, then 500 milligram 500 milligram IV infusion every 4 hours. For maintenance, medications were also continued, such as carvedilol 6.25 milligram 1 tab BID, linagliptin 5 milligram 1 tab once daily, calcium carbonate 1 tab BID, nacaran 1 tablet BID, and sodium bicarbonate 650 milligram per tablet 1 tab BID. Hyperkalemia correction was also started, and patient was started on low salt, low fat, full diabetic diet, no canned goods, no fresh foods. CBS TID AC, CBS monitoring done every TID AC meals and at bedtime, and INO every shift in absolute figures. Patient was then appraised for IG catheter insertion and AVF creation, thus referred to surgery service. Also apprised for hemodialysis. So currently, the patient, for this morning, patient was seen awake, febrile, still with feeling nauseous with body malaise, no dyspnea nor chest pain, not in distress. For the whole night, her BP range would range from 160 to 180 over 90 to 100. Thus, Isocet drip currently at 45 cc per hour, actual dose of 16. Heart rate of 65, or 20, O2 sat of 98%, a febrile at 36.5, with a fluid balance of positive 350. Currently, patient at the OR for IG catheter insertion. Pending laboratories includes repeat serum potassium and urinalysis. Thank you. Wala. Actually, nag-contemplate on ako magpa-PCO2. Sorry, Doc.
For the ADP of the stage, they never mentioned it. You look at your electrolytes and hypertension.
Yes, Doc.
What are causes of hypertension?
Acidosis. No.
Okay, so how does acidosis cause hypertension? Can you give us the types of renal tubular acidosis and differentiate them?
We have quantum. For the renal tubular acidosis, we have renal tubular acidosis type 1, wherein there is distal hydrogen ion secretion defect. Though. For the renal tubular acidosis type 2, there is proximal convoluted tubule defect in bicarbonate absorption. And for the renal tubular acidosis 4, there is aldosterone deficiency or resistance to aldosterone effects. Though.
Okay, so about this consolidation, the details,
For the RTA doc, guys,
like one, classic.
sa distal doc, distal yung type, the type 2 is proximal.
The type 4. Anyway, there's a type 3, what's type 3? Learning siya na related for
RT.
different types of RT.
Okay.
That they go down sa electrons, sa calcium, sa alkaline versus acidic ang urine. Okay.
Okay, thank you, Doc. That's